Good afternoon. And today I have a pleasure of interviewing Dr. Serwan Abdulla, who is joining us from the mountains of Iraq. Good afternoon, doctor.
Good afternoon, Dr. Sokolina. How are you?
Thank you very much to my audience. If you have trouble sleeping or sleep next to snoring partner, and you might have kids, this program is going to be for you. We're going to talk about, I would say, preventative solution for sleep apnea. We're going to talk about orthodontics. And you know, I'm very passionate about this topic. I use orthodontics in my practice for sleep and prosthetic cases, but in general, at a certain point, I plan to be orthodontist, just like Dr. Abdulla, but it didn't happen, fortunately or unfortunately. And if you're a medical practitioner who, just like us, trying to put small pieces of puzzle together, puzzle what called sleep apnea or modern disease of human evolution, this program is going to be for you, because we're going to talk about the solution in orthodontics, what can help permanently move jaws forward and open the airway. Not what I do with oral appliance, what you always need to use oral appliance to sleep well, but something what can be a permanent solution. You know, I talk a lot about orthodontic surgery on my channel, but this is a different point of view, and I want my audience to know about that. And now I'm going to talk how I met Dr. Abdulla from mountains of Iraq and brought him to my channel. Actually, he saw my presentation on MU conference, and due to that conference, I can't thank Dr. MU enough. I connect with a lot of bright minds around the world. So it's really broadened my horizon, this conference. And Dr. Abdulla, we connect, and I find what he's doing and how he practices his orthodontic art and science very interesting, and it can be valuable for my audience to know, and for young orthodontists or for orthodontists who are curious about different ways to know about his technique. And he is the first orthotropist on the Middle East, and he has a lot of courses. So if you're joining from that part of the world, I recommend you to find Dr. Abdulla, and he can help you to learn his skills and orthotropic, what he learned from Dr. Mu. So my first question to you, you know, orthotropics, and we don't like to use that word now, but it's orthodontics, what help the jaw grow, develop for children, but you actively use it for adults. What biological mechanism allow jaw to move forward or craniofacial change after growth is complete? Because for me, as a dental sleep medicine doctor, I have some people who use the oral appliance, and even with the AM positioner, have the jaw moved forward. I try not to have it happen, but it happened. And sometimes I cannot figure out why it happened. For some people who I don't want it to happen, and for people who I want it to happen, it's not happening. So give me your point of view on that question, what puzzled me for a long time.
Thank you, Dr. Sokolina. It's a pleasure to speak with you and your beloved audiences. Thank you for your presentation. Actually, we know that from the genetics that the sizes of the maxilla and mandible are already genetically determined. But the, let's say, the distribution of the bone is not genetically determined. According to John Mu, the inventor of the postural basis of malocclusion, it is the posture that decided wherever the maxilla has to go, wherever the mandible has to go. Actually, in orthotropics, we are working on two lines. At the first line, at the first stage of treatment,
No, good. I said the first.
Yes. At the first place, we are trying to open the airway. This is our first, let's say, first work. After that, we are working on something else which is called postural training. When we open the airway, we could train the patient to close his mouth and to bring his tongue to the palate. Bringing the tongue to the palate will redistribute every single cell of the total face in a new position. So we call this process as a bone remodeling. I think this is what's happening in the adult orthotropics.
So, like, if I rephrase what you said, you first trying to open the airway. You open airway with working with posture and offering them myofunctional therapy, like retraining the tongue. That's and breathing through the nose. That's what you do as a first stage, and as a second.
Exactly. As the first stage, we are opening the airway. After that, we are training the patient to breathe through his nose, definitely not using his oral cavity to breathe, and to place his tongue against the palate.
But I want to be very specific about, strategy of treatment. What appliances you personally use in your orthotropic journey, and how you decide between, removable, fixed, expansion, or functional?
Actually, adult orthotropics is not a choice, was not a choice for me, because orthotropics designed for growing patients, growing child. But since there were no others to help, I was obligated to do that. For cases they asked me, and they asked me to help. So I was obligated to help, and I found lots of benefits. What I use in my practice generally are the traditional stage 1, stage 2, and stage 3 BioBlog appliances. I don't know if you know about the composition of the appliances. We are doing expansion with the stage 1, and we decrease the indicating lines in both the upper and lower arches, making a proclination of the upper and lower anterior teeth. After that, we will shift to the stage 3 BioBlog. The expansion at the stage 1 will open the airway, and when we go to the training stage, we use the stage 3 BioBlog appliance, which tries to improve the patient's oral posture. I always tell my patient, it's not me and it's not my appliance that improve your face and your health. We are aids. We aid you to correct your oral posture. When you corrected your oral posture, everything will go in a straight way and everything will be proven by itself.
This is a beautiful answer. I want to talk about my specific patient who is still growing. He's 10. We met yesterday, it's one of the meetings. We actually working on improving his airway and posture for 2 years already. And yes, I did the first stage, I did expansion, and he had myofunctional therapy. But yesterday I took 3D scan. And just like 2 years ago, even though his palate got bigger, he still retruded. His upper jaw is retruded, his lower jaw is retruded. We got through, I would say different treatment modalities, what you're talking about. But what you do when both jaws are retruded, and even, patient was wearing the BioBlog, but they did not move forward. Do you use reverse, face mask to move the jaw forward, like that?
If I would treat such a case, definitely, since he or she is a growing patient, I will use BioBlog appliance. As I said, when we decrease the indicating lines, especially in the upper, we will procline the upper anterior teeth, lengthening the arch. When we shift to the second stage, these proclinations will disappear slowly in a gradual steps. This will help in, let's say, remodeling of the whole maxilla forward. After we manage the maxilla, the mandible will follow with the aids of the stage 3.
How do you accomplish proclination of upper incisors? You use braces or you use removable appliance to do that?
One of the components of the stage 1 bioblock is a wire which is called catenary wire. By activation of the catenary wire, we are able to procline both the upper and lower anterior teeth. By the way, sometimes bringing the mandible forward will make the chin extremely prominent. That's why lots of time we have to decrease the lower indicating lines as well, so that when we bring the mandible forward, the chin will appear, let's say, normally.
Got it. No, actually, if I would, we're talking about class 3 or, at least in my practice, problem of prominent chin, I don't see really often. Most of the time, people who I see, they actually have a retruded chin. And sometimes retruded both jaws. So I understand with bioblock treatment and all of that, it can happen, but in the real life, I don't see a lot of that problem. I see exactly the opposite that. But now I want to ask you another specific question. Please share with us, Dr. Abdulla, what, we all, if we be very specific, I take cephalometric scan. Yes. And I, use certain markers. But what markers do you prioritize when you decide this case is suitable for adult orthotropic or not?
Actually, we have other parameters than cephalometrics. We call it indicating lines and other diagnostic methods. However, we are using the cephalometrics. The traditional SNA and SMB and AMB angles, these must be, let's say, looked for. We have the maxillomandibular plane angle, which is an important marker when you are treating a patient. It guides you whether your patient is, whether you are directing the patient horizontally, the growth of the patient horizontally or vertically. This is also a very important, let's say, marker. And also, we are looking for the proclinations of the upper and lower anterior teeth, and let's say looking to their relation to the maxilla and mandible, because excessive proclination might cause problem.
Yeah, that's me. I have excessive proclination in my mouth because that was a method of treatment in Soviet Union. So they procline my teeth to mask small upper jaw, but nothing else happened with the jaw. Jaw didn't go anywhere. But so when, what question I want for my audience to know, like if that's possible to grow bone or actually reposition maybe the lower jaw, but it's going to be less retruded. And, just like I mentioned in the beginning, how you have to draw the line. Like this patient have chance with orthotropic and, the retruded mandible may be moved forward, or no, this patient have to go to orthodontic surgeon and, have a totally different destiny.
Actually, class 3 cases are extreme candidates for jaw surgery because we can do nothing with bringing the maxilla forward in extreme levels, let's say. But when the mandible is retruded, even with mandibular advancement devices, you can bring the mandible forward. I think you use it in your practice.
Yes, I use it in my practice, but I bring that mandible forward, not for people who I want to bring the forward.
Yes,
I
yes.
usually for people who I don't want. And that's, $1 million question. When I use this elegant appliance, or little bit less elegant appliance, they all designed to bring the mandible forward. And yes, it's true. I use something else to put it back. Some people don't use it, but sometimes people do use it, but still it get advanced.
Yes.
And then, bite get open, all the troubles happening. But I want to understand from the person who's specifically doing that particular movement, how would I know? Okay, I look at the ceph, I always take a ceph, and I know this patient might move the jaw to the position I'm not gonna like. I'm gonna be very careful. Or this patient have no chance.
Actually, the biology is, let's say, one. We have no biology for a person different from another one. For my cases, every single case, I see the mandible that is coming forward with stage 3 bioblock. Why, in your case, some cases are, let's say, answering and some others not? I think it's related to posture. They cannot keep their mandible inside. That's why the mandible will not come forward. If they, let's say, try hard, they will get the result you want. This is simply the idea. By the way, I am my candidates for BioBlock Orthotropics are almost class 2 cases who have retruded mandibles. I am trying to bring their mandible forward. What I saw in my cases, I am not treating too many cases, too many adult cases, let's say. Might be 5 to 10, but every single case is responding to the treatment very smoothly without any problem.
No, that's wonderful promise for the future of dental sleep medicine, for the future of orthodontics, like how differently we can use. And my question to you, you said posture is very important. So who is your collaborator? You work with craniosacral therapists, you work with physical therapists, or you just give certain exercise to people to have a certain posture, or we're talking only about posture of the tongue?
We are talking about, let's say, oral posture in general. Tongue posture is the most, let's say, important, but we have something which is called jaw posture as well. And we have lip posture as well. These all together composes the oral posture. Actually, I don't have any collaborators since I just have a ENT collaborator. Always, I am when I decide to treat a case, I send the case to the ENT test to know if there is any blockade in the airway, in the nose, any adenoids. Otherwise, I am training my cases through appliance and through giving them instructions to posture their tongue on the palate. Hopefully, the cases when correcting their tongue posture, the other postures will be corrected accordingly. This is what I saw in my cases.
That's fantastic. So tell us, Dr. Abdulla, that what do you want to say to my audience, to orthodontists who are listening? What can they learn from, from your example? You post your cases on Instagram, and I saw a lot of beautiful cases, and I will post links underneath this interview, and maybe some photos of your cases, what people can learn or ask questions and reach out to you. I know you have also presence on the Facebook, and I know you're going to that big Orthodontics Congress, right? Next week, right? In Baghdad?
It's an event in Baghdad, yes.
Yes. And hopefully you're going to bring more knowledge like that to the Middle East. I think it's going to be very useful.
Hopefully.
What do you want to say to the young orthodontists from the cases you learn? What wisdom you want to share?
What I want, there is a story from a Brazilian writer. He was looking to a newspaper. A man was looking to a newspaper with his daughter. He saw a torn newspaper, let's say. The man tried to fix the newspaper. He tried a lot, but he didn't succeed. After that, the man left the room, and his daughter tried and fixed it. When the man returns to the room, he saw that the newspaper had been fixed. Asked his daughter, "Do you fix the newspaper?" She said, "Yes." "How you did?" She said, "I looked to the other, let's say, side of the paper, and I saw a human being. I recreated the human being. That's why I recreated the world." When you are treating the whole face, when you are trying to respect the airway, when you are trying to respect the posture, everything will go to its correct position. You don't need any heavy forces. You don't need torques. You don't need these, let's say, traditional ideas, bringing the teeth heavily to a, let's say, place. Everything will sit in its perfect place.
Thank you. That's such a poetic end of our conversation. Thank you very much, Dr. Abdulla. And we wish you a lot of success on your big meeting in Baghdad. And I'm looking forward to learn from you. Thank you.
Thank you very much.